Thank you, Dr. Harish and your team for such a nice arrangements and having such a nice conference. And my half of the work has been done by Dr. Ganga Shankar. So starting with the pre-op workup, apart from routine pre-op workup, I'll talk something out of the box just to think and implement on that. A good preparation is the road to the post-operative success. This should be in our mind. So there's nothing alternate to a good pre-operative history, investigations, and coming to a proper diagnosis so that you are ready in your mind what you have to do in the OT, what you are doing on the OT table. So a personalized assessment, it helps to tailor the surgical approach to each patient's specific needs, and that's enhancing the chances of success and smooth recovery in the post-op period. A comprehensive medical history and physical examination are essential. There is no alternate to the history. History tells you everything, and we should have ears to listen the patient's every silly things also. We should have a watch in our wrist which have a time for the patient to listen. And apart from the routine history, one should know the family history of ulcerative colitis. Because so many times, if you come across to a patient, there is a bleeding per rectally, we should not jump to whether it is a fissure or it's a hemorrhoids. And even if we see some inflammation, some inflammatory patch in the anoscopy, we should not jump it's a hemorrhoid. Sometimes we may put our head into the anal canal if we jump to the like it's a hemorrhoid, and if you are going for a band ligation or something surgical, you may put your head into the anal canal. So that's why his family history of ulcerative colitis, if it is there, then it's an indication for doing colonoscopy. So proper history is a must. So also the comorbid conditions, whether suffering from hypertension, diabetes, any cardiac ailment, any previous history of same disease is a must. Any previous surgeries for the same or something else has been done, that should be included in the preoperative workup. And any renal or liver compromised states should be taken in consideration. And any history of bleeding disorder, or if the patient is on some anticoagulants, ecosprin, clopidogrel, one should note that, because you need to stop these things 5 days prior to your surgical intervention. And yeah, that's what I said. It should be stopped 5 days prior to the surgical intervention. The preoperative investigation, it can be selectively conducted based on the patient's medical history and what we are getting into the physical examination. And one should note that if you are planning for methylene blue injection for pain or investigation, the patient should not have G6PD deficiency. Now coming to the counseling part. This is a very important aspect of our practice, whether you are dealing with the hemorrhoid, whether you are dealing with the fissures, or whether you are dealing with fistula. Now in any surgical procedure, according to the Supreme Court's one of the judgment, your counseling for any surgery should include at least 4 things. The number 1, the surgical procedure which you are doing, it should be explained what you are going to do in the operation theatre, what you are doing, what you are going to do on the body of the person. Number 2, what are the complications, the potential complications which are possible. Maybe the remote chances are there, maybe 10%, maybe 1%. You should enumerate those to the patients, what are the potential complications that could be involved in this procedure, what I am going to carry. Third, if not done this surgery, what will happen to the disease? What the roadmap the disease process will progress, what complication can occur, what the harm to the person can occur, this you should elaborate to the patient. And fourth, what are the alternative remedies or alternative procedures, those are available for this type of disease, that should also we give to the patient, so that patient can have a choice, and he should not say, okay, doctor, you have not told me earlier about this ailment, that such other remedies are also available, so that I could have opted that. So these 4 things should be satisfied on the paper in the counseling table to the patients according to one of the judgment of the Supreme Court. Similarly, the counseling, you should be very smooth, very crystal clear. It should be a very soft pitch with all your smiley face, so that it makes the patient, it increases the patient's confidence in the treating surgeon. Now, one should accommodate the patient and more than one relative for the counseling. I tell you one example. I had a patient of bleeding PR. She was a lady of around 42, 43 years, and she came with her husband. It's a very interesting case. She came with her husband. Okay, sir, I am having bleeding PR. I did her rectal examination. There was a growth in the anal area, and I sent the lady outside because I did not want it to tell the things what could be the possibility. Husband was in front of me. There was nobody in the chamber, me and her husband. I told him that, sir, there is a growth and I need to go for biopsy, and it seems like there could be a malignancy in this case. So, okay, he said, and he went just outside. I thought he has gone outside to consult her wife, she needs a biopsy. He came in again in the chamber and said, sir, give me some medicine and we'll come after 2 days. I gave some laxatives. So they didn't turn after 2 days or 2 weeks. After 2 months, the brother of that lady came and told me, sir, you are not diagnosed properly. My sister was having cancer and you didn't told us. I said, who is telling you? Well, sir, we took the patient to another big city near us, and there they took the biopsy, and that was diagnosed as a malignancy. I need to continue. Yeah. So I asked him, show me my OPD paper. There in the corner, I have written advanced biopsy. Patient is not willing. Explaining the needs and the risk of this. And after 1.5 months, the lady died. And to my surprise, after the death of that lady, in less than 30 days, he had a new wife. So he might be in confrontation with her existing wife. So that's what I said, you should have at least 1 plus relative, more than 1. So that if one person hides, the another person will pinch ki nahi, doctor sahi bol raha, you have to go for this kind of investigation, you have to do this kind of procedures. So this is one incident occurred with me. And documentation in patient's vernacular language should be there. And documents, the silent points to be written by patient in his own writing, the rest can be printed one. Again, one Supreme Court citation I want to quote over here. There was a case against LIC compensation, Life Insurance Corporation, on a deceased. The Supreme Court given the verdict that everything was printed. So the person who signed it, he cannot sign 25 to 30 pages for reading, number 1. Number 2, he has got the faith on that agent or on the doctor, that's why he signed it, because of the faith. Number 3, he thinks, if it is a printed, the printed has to be same for everybody. So I'm not exception. I'm not a nephew to the Prime Minister, so I should sign it. So in my practice, in the counseling form, in the consent form, I do print most of the things, but I leave few things blank to be written by the patient's own pen in own handwriting, silent features. And few more lines I keep in the bottom by the patients to say my remarks, what is my version. So we should give a fair space for the patient's version. This is my practice. The counseling, again, the preoperative counseling should include infection or bleeding and the chance of the recurrence, the procedure-specific complications, and educate about the post-operative pain management, the wound care, and duration of required healing. This is most important for the patients of fistula. If a patient happens to recur in the fistula, he will blame you that you have not operated properly, you operated wrongly. So keep always a gully to the escape. Always tell the patient there are chances of 2% of the recurrence or 10% of the recurrence depending on the procedure and your expertise. So that leaves a gully for you to run away. There was a chance of 10% of recurrence. I don't know whether you fall in the 90% lucky or the 10% unlucky persons. So Dues for the consent, that will, I think Dr. Rajshekhar will be telling about the legal aspects of in the proctology. But in brief, it should be in the patient's own language. The patient should be aware of alternative therapies, the procedure's specific complications, and any possibility of any additional procedure or change of plan must be documented preoperatively. If you want to divert from your existing procedural what is in your mind, you should also give a hint to the patient and take it into the writing on the documents, and the general consent you try to avoid it. The anesthesia evaluation, not much of to say on that. It ensures the patient safety, it optimizes the perioperative outcome, and it minimizes the risk of complications related to the anesthesia. The bowel preparation, we all know as a proctologist, and nothing much in that. And just special consideration, touch and go. If the patient is on anticoagulants, as per the American College of Chest Physicians, the LMWH should be suggested only for patients who are at a higher risk. Otherwise, the clopidogrel, warfarin, these all should be stopped 5 days prior. And immunocompromised patient, one should try to avoid the surgical intervention because of increased risk. Post-op management, seeds bath. I will tell about seeds bath in my next talk in detail. And dietary counseling, try to avoid the fiber diet, because fiber diet increases the distensibility and gives more pain. So try to go for a stool softener. Should be avoided hot, spicy, chili diet. Everybody knows about this. And proper analgesic. The recovery track counseling is a must. About the tentative time period, what is required, the time required for fistula is more. So this should be emphasized to the patient. And any recurrence should be told if the patient is symptom free for 6 months, so there is no question of recurrence. It may be a new etiology. Thank you so much. If any question, I welcome. Yeah, please.
And warfarin 5 days. In normal practice, what we do is we start shift them patients to the low molecular weight heparin.
That's right.
And that we can stop 24 hours prior to it.
That I said, if the patient is on high risk, you can put on the low molecular weight heparin. But this was the suggestion from the American College of Chest Physicians. But in our practice, we stop 48 hours prior the ecosprin.
And another thing is, see, most of the books write same post-op suggestions, right? Increase in the dietary fiber. But in India, we as such our diet is rich in fiber. So as correctly pointed by you, in the fisher, especially patients, we should not give the fiber. We should give them the
fiber diet one can have, not the bulk laxative.
I'm talking about the bulk laxatives only, that containing that isabgol and all those things.
Right.
We should give them the other laxative which doesn't have this,
stool
especially when it
softeners.
comes to stool softeners,
Be.
because our diet is as much rich in the fiber. And third thing what I want to point out is that is the counseling and the consent same thing?
No, counseling and consenting consent, these are two different things. And nowadays the practice, the ideal practice should be, in the era of consumer forum, one should have a verbal counseling, one should have a written counseling, and one should have a video counseling also. That should be a record. This is a must, what I have emphasized in earlier my talks also elsewhere. Everything is recorded in the video, and everything what the question the relatives those are asking, you can have a proof of that.
In the consent form, the possible complication has to be written by the patient or by the doctor? Doctor
has to write on that, but he should endorse that the possible complications are explained to me and I understood it fully, and still I agree to the procedure what the doctor has suggested for.
So this much note at least should be.
Yes, this should be in his writing.
Yeah. Okay.
Yes.
That should be the take-home message. Yeah.
Definitely, that's a take-home message. According to the guidelines of the Supreme Court, everything should not be printed. As I told you, 3-4 points. Any more questions? I will welcome.
Yeah. Good morning, sir. I am Dr. Ramesh from Hassan.
Right, sir.
I have a very strange question to you because you mentioned about the post-operative management.
Right, sir.
Nowadays, of late, I have seen many people, particularly in the IT sector, they are telling that we have got a piles problem because he is sitting for a long time. It was the biggest thing even I have seen in the social media, even the doctors talking about those things. That's number one. Number two is, the second question they ask me most of the time is, can I do the driving, particularly two-wheelers? Maybe a hemorrhoids or maybe a fissure or fissure, whatever bottom surgeries are. Is there any scientific work done on the position of the patient post-operatively, hastening the recovery of the procedure, or is just a cosmetic and supportive? Your opinion, sir? Thank you.
This is neither cosmetic nor any study has been done. Depends on the symptomatology of the patient and pain perception of the individual person. If he is able to carry if he is able to sit normal on the without cushion, normal chair, so he can drive the vehicle. It depends on the clinical symptomatology of the patient and pain perception of the patient.
Because the drivers, particularly, I have seen most of the drivers coming and telling, because he is sitting, do I need to alter the chain? Do I need to use the. There are so many things in the proctology is confirmed. We are bombarded. So many things. We have no answer for most of the things. I just want to know from the senior people, is there anything like that?
Sir,
That's the reason I put
in
this
today's
question.
world of minimal invasive surgery, what we are doing with lasers and chief test procedure and others, so there is early back to the work tendency of the people, but still some latent period, like 1 week to 2 weeks most is more than enough. Thank you so much.